Hi, I'm Jilly Bond. I'm a pelvic health physio and doctoral researcher, and this is Virginia Rivers-Bulkley.
Hi, I'm Virginia. I'm a pelvic health physiotherapist with particular interest in persistent pelvic pain, and we are here together at the World Congress on Endometriosis in Edinburgh 2023.
Woohoo! We've had a great time. We thought we'd sit down and share with you our takeaways as physios working in pelvic pain. This is aimed at mostly physiotherapists working in pelvic pain population, but if there are anybody who has endometriosis watching, hopefully you might find this interesting as well. But this is a bit of an evidence update of the things. A lot of people aren't able to make the conference, so we just thought we'd download kind of an impossible task. But download our kind of top tips, our takeaways from each day, the things that are more clinically reasonable. Now, if we end up talking for a long time, this might be video one of several videos. And you'll see that I put up throughout this, you're going to see photos from the actual conference of the slides of people talking. So hopefully this is interesting. So we've just finished our time at the World Congress on Endometriosis 2023. And it was great.
It was
really good. One of the best conferences I've been to. I think the last time I was this excited at a congress was in Washington, when it just felt like abdominal pelvic pain, they were my people and everyone's doing so much exciting stuff. And then when they came to London, it was a smaller group, it wasn't as big. But again, everyone was doing such exciting stuff, really working hard in the world of pain and excellent science. But it was kind of that on steroids.
It was. And I think that historically I've always thought of this conference as very surgery heavy, potentially a conference for surgeons. But I do think that the organising committee have made a real effort to make it more inclusive and interdisciplinary this time around.
Massively so. I mean, we had streams dedicated to conservative care with there weren't a lot of physios, but there was physio mentioned in every single stream that we went to, and the role of physio. It wasn't just it didn't feel like a what's it called, like when people just mention it.
It wasn't kind of a token gesture.
Yeah, it wasn't token. It was like we need to send patients to physio. They do better there. They're not going to do well in this kind of treatment. But we had sessions from dietitians, we have psychological interventions.
Lots of clinical psychologists.
Lots of clinical psychologists, pain psychologists, basic science. We did have surgeons, but we also had obstetricians.
Yeah.
Who else can you think
Had rheumatologists.
Rheumatologists.
From the pet giving us some pain context.
Gynaes, loads of gynaes, some endoscopy people, lots of imaging.
Sonographers.
Nurses, there was a whole nursing stream. Lots of digital minds, loads and loads of kind of scientists of unknown origin. So
epidemiologists and people with the numbers.
But it definitely felt like it was just so exciting. There were more than 50 different countries represented. And just so exciting. So exciting being around so many people all working towards the same aim of improving the life of women with pelvic pain, with endometriosis pain and endometriosis symptoms and endometriosis infertility and everyone working towards that. And the other thing that we noticed, and it took us until today to notice, is that it was actually really heavily female led, which is probably why it felt so comfortable and so caring and
without stereotyping.
I think I've been to some of a lot of the European conferences which are a lot more surgical heavy, and obviously there's a lot of women there because there are a lot of female surgeons, but they tend to be male led, male panels and things like that, and it's got a different feel. But this was much more integrated into the fact that there were many. I think we turned around at one point and realised that the whole day so far, and it was about 11 o'clock, and it started at 8 a.m. every day and went till 6 p.m. every day. But we realised that the whole morning we just had female presenters, female scientists, female...
And facilitators up on stage, hosting each of the streams, as well as the key speakers.
Yeah, really impressive.
Physio keynote speakers, people from different professions highlighting the roles of others, proper interdisciplinary conversations.
Yeah, not token, but really highlighting, truly believing in the role of psychology and complementing each other. But every single stream was really well thought out. complementary and incredibly diverse. So we had, it's very common when you've got, I guess the World Society for Endometriosis is incredibly diverse in its geographic locations, but it's really common at conferences when you've got certain leaders in the field. They will always look to the people they know. Of course they will. But it really felt like they'd gone to kind of all of the corners of the world, all of the edges of the little pockets, not just the big endometriosis centres, but they'd really looked for who's doing cool, interesting stuff that the world needs to know about. And they brought all of those people. So we're going to talk to you about those people now and give you a little update. Virginia, do you want to get us started? So on Thursday, we started.
Yeah, so the first session we went to on Thursday morning was psychology and sexual function, which was a great start to our 3 days here. So one of the first speakers was Emma Evans, a clinical psychologist at Oxford, both at Oxford University Hospitals and doing research with the Oxford network there. And she was talking us through the broad introductions before we broke down to some of the other speakers about what does psychology and sexual function look like. And she was broadly bringing us back into the biopsychosocial model of pain and how the model of pain can also help us with the model of sexual dysfunction. So understanding patient-centered care. And one of my favourite things that we both tweeted about were some of her visual aids. Because some of the literature she cited was stuff that we might be familiar with. Again, we shared some of that content online. But she used a beautiful visual that I thought, which was a kind of ring pie chart where she was breaking down the components of the biopsychosocial approach to pain and sexual dysfunction, but then used examples of how she uses that to deliver patient-centered care by individualizing it. A bit like us all having slightly different versions of the same pie chart, so that things were weighted slightly differently. And she reminded us that not only would that vary person to person, but by moment in time. So it might be that we start off with a particular representation, having used some psychometric testing and conversations with the women we're with, but actually by revisiting that at later dates, it might help us prioritise care, prioritise different members of the interdisciplinary team to get that right care for the right person at the right time.
Yeah, we all know we're treating pelvic pain patients for a long time. Treatment isn't a week and done. And if you're 6 months into treatment, you've done those psychometric tests to begin with and your physical exam, and it may be actually you need to revisit them and say that person needs to now go to psych, this person actually now needs to go to the medical care. And that's a changing need. So yeah, okay. The next thing was Dr. Lisa van Niekerk from Tasmania, who was brilliant. We really liked that session, all about body image and sexual function and psychological well-being. And the main takeaway from that was that there was a bidirectional relationship between pain and quality of life. Meaning, if you change someone's quality of life, their pain can improve. And if you improve their pain, their quality of life can improve. So we can be, we're really cited well within physiotherapy to be working on those two elements. It's well within our scope of practice. And she really pushed for a proactive engagement in allied health professional care rather than a reactive. So especially with those people with endometriosis, we don't want to be getting them when they're in crisis. We want to be looking at how we can stand alongside them and provide slightly preemptive care as we start to see that there are deteriorations in their quality of life before they get to the point of crisis and have to wait a long time. I mean, that's a pie in the sky best case scenario, isn't it? From not really realistic. Anything you want to add to that one?
Just that if you don't want to see all the details right now, but actually we both tweeted some of her content looking at numbers of laparoscopic surgeries in women with endometriosis and some of the associations, unfortunately, with lower levels of sexual function and higher levels of dyspareunia. So again, tracking that levels of intervention and really trying to optimise if they are going for surgical care, the number of surgical episodes and how that might fit into both their quality of life and exactly as you were saying earlier with that body image, sense of self and other quality of life factors.
That's something that came through many of the different streams, and it was an absolutely fantastic conference. Really, really open and holistic, and very holistic in the truest sense of the word, and that all professions were encouraged at an incredibly high level of presentations. But that there was a commonality to the number of surgeries that people had had, people that have had more surgeries presenting with more complex pain-related symptoms. So something to look out for. The other, I don't know if this one was in this, I don't think it was in one of the presentations in that block, was putting forward that patients want to be asked about sex. Sex is a key function, and they feel that actually it's clinicians that are embarrassed to talk about it and ask the question. So really, as clinicians, we need to get over ourselves, have the training in how to ask it and ask questions around sexual function in a empathic and appropriate way. But we need to be having those questions and get over our reservations. Okay, then on to the next, the first keynote. Do you want to talk about John Cryan?
What a great speaker. What a great speaker. So this was a keynote on the relationship between what we know about the gut-brain axis and visceral pain, from John Cryan, who works in Cork, and he was a great speaker.
Really,
lots of great content.
Really good.
So he spoke a little bit about some of the things we might already know about the gut-brain axis. Some of the references we might have tweeted might be familiar, building on the work of others. Something that was really interesting for me was seeing how the journey from those rat models into women, into us human participants, and particularly a little reminder that I made for myself to consider what we do now know about the psychobiotic angle. So he spoke about the psychobiotic diets, linking obviously microbiota, into that whole body syndrome of gut-brain axis associated with persistent pain. And he specifically spoke about the fact that microbiota, I hope I'm saying that right, and sex hormones are now established and considered to play a role in the modulating pain sensitivity in visceral pain syndromes.
Yeah.
So it's not just kind of abstract thinking anymore.
And it's solid science. Yeah. What's going on in your gut is going to have an important role in your expression or of embodiment of pain, your experience of pain, and how that is modulated. So it isn't just about getting patients to eat sauerkraut. It's about getting a wide variety of diet, including fermenting foods. But really, he talked about the microbiome being inherited from your first female parent at the point of delivery, and how that's altered with C-section and stuff like that. What was really interesting is that they've done lots of models in mice where they have clean mice. So they have mice where they've removed the microbiome, which sounds really cruel. And in these clean mice, where they have no microbiome and they're not in an environment that contains microbes, they show real social issues and socialization issues. They also show altered pain perception and altered, I can't remember, some of them have symptoms that if they're put in the situation when they can go and play with another mouse or be on their own, they'll be on their own, which is not normal mouse behaviour. But what they did find is that if they transplanted normal mouse poo into these clean mice, which is pretty grim but a helpful idea, that these mice returned to normal social behaviour. So again, it's a concept around changing the microbiome, and how that changes our social behaviour is a big, interesting, challenging concept, but it can have a massive effect. So and it doesn't take long. He was saying that it takes a number of months to restore a microbiome, and that they do that through adaptation to microbes. So if we can get people improving their diet, reducing the highly processed nature of it, and that's looking at really common sources, and things like bread from the supermarket is highly processed. We can reduce those processed things, getting people eating food that they've cooked and made themselves, not necessarily bread. We all do love a bit of sourdough after the pandemic. That we can improve possibly also the psychological and the social elements of quality of life disturbance in people that have been in pain for a long period of time. And as we know, that's got much more of a bi-directional relationship than we thought it did. We thought it was very much pain was creating problems with quality of life. We now know it's bi-directional. So that was a really interesting keynote. Have a look at our Twitter for lots of pictures of it.
And it was a bit hopeful, because actually he reminded us that while we've obviously got that genetic predisposition, while we can't change our genome, we can change our microbiome.
Yeah.
So it's a positive, empowering step, potentially.
Okay, on to the next bit, which is the last afternoon session before the last keynote. There were a couple of tools I mean, there's so much in this conference. There were like four streams in each option, so you had to choose to go to one of the four. You could dip in and out, and each one of those streams had kind of like 6 to 8 presentations, and like the amount of high quality science was incredible. In the next one that we went to, they presented a couple of tools, one being the rate tool for raising awareness tool for endo, which is the tool that's being trialled in GPs, which is something to look out for. It allows people to, they're trying to get better at diagnosing early, because we know that the burden of diagnosis is about, on average, 7 years for women to live with symptoms before they get diagnosed, but it can be, 10, 11. And then there was a really interesting tool for predicting flares, which can, again, the issue they were trying to tackle is that women have a great amount of fear and burden around the impact on their quality of life from being scared of when the flares are going to come. So actually being able to track your normal data around your period and what are the symptoms you've got of your guts, or if you've got any brain fog or aches and pains, putting this all into the app, and it was then able to predict whether or not you were going to have a flare. And what they did is they took all the data and they found predictors, and one was if you had a period, you were less likely to have a flare the next week, and if you had a flare, you were more likely to have a flare the next week. So it's a bit dubious. I mean, it's at the beginning stages of retrospective data analysis, but
it was an interesting example about using big data and AI meaningfully to support women. But I think talking to some of the other pain physios, pain clinicians in the room, I think we're not yet at a stage where we would obviously want women to depend on that kind of data.
Yeah.
But it was an interesting concept.
Yeah, and actually taking away the fear of a flare by improving their ability to manage flares and finding meaningful ways for them to engage with their pain while they're in a flare can reduce some of that pain. Or that fear, sorry. So the next two things have you got anything else before, Jen? So the next two that I've picked up, which are kind of two from different sections, but one was in this one, was two interesting studies coming out of America looking at racial issues in endometriosis diagnosis. So the first one from this session found that was a study from the gynecological service at one of the hospitals that black women were more likely to have a diagnosis of uterine fibroids and not endometriosis, and there was a racial disparity in that, and that they talked about the fact that historically, and they showed I'll put it up on the screen now. But historically, there was a misconception that black women didn't have A, the same amount of pain, or B, they didn't get endometriosis, when actually they just weren't listened to historically. So this has kind of created this perpetuated myth of black women don't get endometriosis, but really what they're finding is that is now creating a situation where more often than not they're diagnosed with fibroids, and that's the reason they have their a hysterectomy for fibroids, when actually it may be that they've got underlying endometriosis. And they were looking at using this as a way to kind of spearhead a change in weighting the systems more towards looking for and searching for endometriosis in women from an African American background or an African heritage. There was another study later on that also pulled this on in the racial element, looked at endometriosis and an ovarian cancer risk, and found that both white and black women had an increased risk, but there was a difference in the rate at which black women were assessed and picked up for it. Again, highlighting these racial disparities and the fact that within medicine we need to be looking for things more and dispelling these completely outdated myths about racial differences. There are some genetic differences within populations, and we see that classically in prolapse. The studies that are coming out in Nepal show alterations and an increase in prolapse, but the data with that needs to be drilled down more, and there are far more nuances within cultures and subcultures, and it's not just a skin colour issue. So a bit of social justice in there, actually quite a lot, and there was a huge amount of patient voice in the whole conference. Lots and lots of studies quoting patients, being led by patients.
Some co-design, some nice community engagement.
Yeah, patients really involved in developing the research that was coming forward. Okay, and then on to Jen Gunter.
which you were there.
Yes, you were not.
I was not.
So she was busy. She wasn't avoiding Jen Gunter. She would have been there.
Although I've actually got more to learn on this social media topic than you do. So
Yeah.
I should have been there.
Well, would you like to listen?
Yeah, I will listen.
I will put up lots of slides for you. So Dr. Jen Gunter, who we all know from Twitter, is a really good advocate for kind of creating and getting rid of myths and creating truth online, and using social media as a way of improving the healthcare understanding and education of everyone. She looked at whether social media is a curse for the endometriosis research community or not. And she talked about that people use social media for a variety of reasons, and I'll show this slide now, and you can see there's a huge amount of reasons why people use social media, and some of them are surprising and some of them aren't. She talked about the illusory truth effect, which was really a beautiful discussion about how when we see a fact or we see something on someone's feed and then it's picked up by 3 or 4 other different people who are not necessarily experts, but there may be people with lived experience or people with an interest in it that repeat it or retweet it or share it, that actually the seeing of a repeated concept has the greatest impact in a very short time in changing the narrative around actual fact. So we saw this, and they've tracked it with the misinformation around COVID vaccines. And that the issue we have is that translating the guidelines and medical stuff, the reality and the facts behind where we are, and the fact that it is changing all the time. And this is what research does. We find something, we change it, we update it. But it's not really pithy, and it's not if you look at the guidelines, the ESHA guidelines for endometriosis, it's not kind of social media friendly necessarily. However, she does think that it is an asset. Social media is somewhere we need to be. It's where our patients are. Most people, something like 50% of people find out about endometriosis from social media, and they tend to be the younger group of patients. So we need to be on social media with the right information. So if you're watching this and you're a clinician, make sure what you're saying is evidence-based and current. Do the most you can to get real facts out there, and to gently dispel the ones that are not helpful. She says that it's also a great way of allowing clinicians and research to connect, but medicine and society have allowed a gap in the research to be created around endometriosis specifically, and it's a really good way of seeing how those gaps are being filled, which tells us about the wants and needs that are unmet in our patients. So we can look for the misinformation and then try and create useful information posts to help that. It's really hard to do, especially when you're busy, you've got home life, you've got activities, hobbies, you've got work. But I'm certainly going to start trying to be more regular with posting. I haven't for a couple of years for family reasons, but I'm going to try and get out there with more evidence-based information, especially around endometriosis. And now we're going to talk to you about Friday. So Friday, favourite day, started with
non-pharmacological and non-surgical management.
And our favourite person,
Helena Frawley.
Hooray!
So obviously we have some biases here because big fan of Helena's work and her communications, but it was really nice because she was given the broad topic to start that morning, giving us a fantastic overview of where we are, particularly from a physiotherapy point of view, looking at the evidence for management of symptoms associated with endometriosis-associated pelvic pain.
Yeah.
And I think what was lovely was that whilst we're here at the Endometriosis Conference, and obviously that's what we're here to talk about, obviously Jilly and I are here with our broader pelvic pain hats on, and so much of this content is relevant to everyone that you're seeing with persistent pelvic pain.
Absolutely. And it was on the biggest stage. So that auditorium held like 1,000 people, I think.
I mean, I didn't count them, but it was a good turnout.
It was
big
huge,
stage,
huge.
big profile.
Yeah, there were easily a good couple of hundred people there. And that's also not common. So it's not common for the consultants, the surgeons, to go to the conservative management streams. And it's very frustrating as people that stand on stage and talk about conservative management and its value at some conferences when just you don't get any surgical bods there because we need to integrate and work together more. This was a really good turnout, so exciting. So Helena talked about lots of stuff. One of the first things I picked up is she just went through the new IASP classifications. If you've not come across it, I the use of the word chronic primary pain, so pain that's not necessarily associated with a biological driver as it's a symptom of, but just that chronic primary pain that exists without necessarily identified cause, or pain is a primary issue itself. There's a better definition of it there somewhere.
And she spoke really nicely about the chronic overlapping pain syndromes that we know that exist, but how they're disproportionately represented and seen within the pelvis. So actually we can think about some of our pelvic pain within the context of pain that might be limited towards overlapping syndromes within the pelvis, but also then within the context of that widespread pelvic pain, touching on the work that's been done by MAP and others looking at pelvic localized pain versus widespread pain.
Yeah,
exactly. And in the assessment element, she spoke nicely about psychologically informed physio practice, the use of proms. She gave us, we might share some of the slides from her.
Patient reported outcome measures.
Thank you, very right. And also was talking about Paul Young and team's work, phenotyping endometriosis associated persistent pelvic pain in particular, from type 1 to type 4, depending on some characteristics of that pain.
She discussed some of the unknowns around physio treatment, and the fact that we know that physio as a conservative measure is incredibly useful and significant. It's, our evidence base has moved up into kind of the higher level evidence for physio input, but that we don't have the specifics yet of what combinations we should be using it in. Is it with something else? Is it on its own? And who should we be doing what type of thing? And so there's still a lot of work that needs to be done there. And she brought up a reference to our favourite reference and our easiest takeaway of the whole conference. Whose work was it?
Mitchell. Alice Mitchell.
Alice Mitchell's, yeah.
2023, because it was here.
Coming out of the wonderful research base in Australia that we love. Who identified through interviews with patients that we shouldn't be using the word bother and bothersome symptom, and not talking to patients about what's your most bothersome symptom, because that's really, there's a word.
The feedback was that it diminished and
it's
rather than
diminutive.
validated. Exactly. It didn't validate their experience as much as impact. So they wanted to talk about what was the most impactful symptom and the impact that that symptom had on their quality of life. Whereas the perception, speaking to the researcher at her poster, was that a bother is something potentially minor. Oh, it's a bit of a bother.
Yeah.
Compared to a significant impact, or they can rate the degree of impact, but the perception from the patient community was that that was more validating than bothersomeness.
Yeah, don't ask them, because symptoms don't bother patients, they ruin their lives. So yeah, we need to be doing that. And she also put up a lovely infographic from her paper with Katrine Peterson in a textbook last year, 2022, that I will link below.
Yeah.
I'm sure we can get it on there somewhere, but I'll show you now this lovely infographic about kind of best management in pelvic pain.
And what's beautiful about it is it starts off with the umbrellas that we might expect: the biopsychosocial approach, person-centered care, multidisciplinary collaborative care. But then as you have a look at it, you can see that there's some of the general advice for that whole person care, but it also points towards what might be particularly added from a pelvic floor service or pelvic floor specialist, pelvic health, along with the pain management focus. Because as we know, some of you will have both hats on in your service, but it's also a useful tool if you're talking to kind of collaborators or MDT members of actually why you might need both elements to your practice or service for service delivery.
Absolutely, well said. Okay, onwards to my least favourite study, which we're only mentioning briefly because I want to pick up on it as not a useful thing to be thinking about. There was a study brought up that looked at MRI imaging of the pelvic floor, and they made assumptions around the thickness of the pelvic floor muscles made on MRI, and assumed that a thick muscle was a painful muscle. And as we know, pain and muscle tonal changes or thickness are two symptoms that are concurrently often seen, but they are separate symptoms that need to be recorded. A tight or a muscle with increased transient tone is not necessarily a painful one. As we all know, we have plenty of people that are walking around with very higher tone, increased transient tone pelvic floors than others. But there was a really good question. They also pointed out, they used the word trigger point. They did lots of stuff and saying, well, the left side was more raised and the left side had endometriomas on it and stuff like that. And you'd expect that if we've got some inflammatory cause of localized nociception, you'd have a potential local spasm. But you can't say that it's painful, and you can't say that it's in spasm when you do a supine static MRI. An MRI is a photograph. It's just saying what is happening in that moment in time, and it could be the people were in a position, and going into an MRI is scary. You're in a tube, and we know that the pelvic floor is one of the first muscles to tuck up and react to anxious situations. So there's many confounding reasons why I don't like MRI studies that look at tone. Because again, tone is an aspect of active, I'm going on too much, I know, active and passive elements of the muscle function, and really you want to get EMG in there to look at the active elements. So
we can point you towards a colleague's work then.
Yes, go and check out Rachel Warman's systematic review on tone. I will put a link below if you haven't read it. It's really important. I am a word pedant, and it's important that we're all using the same terminology. So go and look at Rachel's work.
But can I say the positive that I think from that study, or that being included, was the consensus afterwards.
Yes.
So actually the questions in the room, I think quite rightfully, gently challenged the terminology used. And the consensus that came from the facilitators in the group, Helena and others in the room, was that we're now at a stage where we can say we've moved beyond trigger points.
Yeah.
That's not what we're looking for.
No. And in fact, Helena's ICS terminology report 2021, 2022, can't remember which year, but it's recent. They've moved officially into using the word tender point or tender spot, tender point instead of trigger point. We have no evidence for trigger points. We're not quite there. So onwards to useful stuff. We had a couple more in that session. Oh, you can do that one in a second. I've got the diet one. It's our favourite trial that we both want on. So there's a really nice one from Dr. Astrid Cantino. It was a Dutch team that looked at diet changes in endometriosis. And they did some simple diet interventions around wheat and vegetable input and changing soy. And I would, go and have a look at their work if you want to look at the specifics of the diet. What they found was they used a 5-point Likert scale, and they found reductions in bloating, constipation, diarrhea, fatigue in patients, and pain. And the bit that was really important is that 67% of patients reported pain in their group, and there was a mean reduction in their Likert scale score of pain from 3.91 to 2.52. Basically from nearly 4 to 2.5, which is a 1.5 point change on a 5-point Likert scale. And we know our minimally clinically important differences. So when we know we're doing a good job, that's in the real world has made a difference. On an NRS scale is 2 points on a VAS, or on a visual analog scale. So they've changed it in the equivalent of 3 to 4 points on a VAS score. So it's a really clinically important change. They also found, which was really interesting, and again it goes back to this theme of when can we catch people. If we can catch them with endometriosis early, if they don't have this burden where they're walking around with symptoms for years, not getting diagnosed, if we can get them earlier, we can get them on treatment that's more relevant, more individualised, we can help them more. They found by analysing subgroups of their data that patients who had more previous surgeries or had previous surgery, so laparoscopy to remove lesions, had an even better response than those that had no previous surgeries. But the difference was that the people who had previous surgeries started at a higher level, so they had more quality of life distortion, more quality of life issues, more pain, and they had a greater response to changing diet. So diet's definitely something we need to think about. We've already talked about John Crichton's talk about the microbiome. We need to be referring to our dietetic colleagues. The big one from this was don't just send them off to kind of look at diets that they can do. We all know there is loads of stuff out there for avoiding Mediterranean diet or doing anti-inflammatory diet. but really getting professional advice from a dietitian that's trained in specific diet endometriosis needs in the women's health prevents deficiency in their diet, and also it helps them to reduce the fear of dietary triggers or changes. And a lot of women, I know from the bladder pain syndrome population, won't eat tomatoes or avoid them because they think they're really triggering, acidic for the bladder. But actually a lot of women can eat them, but they're just really afraid of eating them because they've had such horrendous flares. And the dietitian is a really good place to start with working out what is actually going to be a flare for you, how to manage it, and preventing deficiencies. Onwards to our favourite study of the whole weekend, just from a fun point of view.
The reason we both got quite excited is it's about environmental enrichment, and we all now know how important context is to any pain experience. But the reason we quite love this study is it was from Idalis Flores and her team in Puerto Rico, and it took their previous work in rat models to a patient population of environmental enrichment, taking them to wonderful places to do nice things, lots of happy homework, things that they enjoy.
Novel input, play,
beach,
fresh
air,
yoga,
things
water,
with
palm
positive
trees.
connotations, positive context for environmental enrichment.
Yoga under palm trees.
Exactly. Everything you might want to do for self-care and joy. Bringing joy to your day was something she mentioned. So actually there was no change in the pain scores, but they had positive effects, statistically significant positive effects for anxiety, depression, quality of life and stress scores from that study.
Yeah, it's brilliant, and we all want to go and jump and join on it because it was very well presented. One of the nicest things is that she did a really good job of presenting where they didn't make change, and it's such an important thing in science to present when things don't work out or you don't find a difference, because there's a massive amount of bias of just presenting the stuff that looks good. So they didn't do that. They said, look, we didn't make a change in people's pain, but they coped better. They felt like they could cope with life. They felt less anxious. They felt like stressed. So that allowed them, it's one of those things when we talk about the 1,000 little things that we need to do to improve someone's quality of life, improve how they're coping with something, to allow them to live a better quality of life. But also it reflected very nicely all of the evidence we see in bladder pain syndrome about environmental enrichment, which is only getting to the fore with human models in actual patients. But if you remember a while back,
you have lived experience.
I have lived experience with my feline. So my cat Stuart, I did a video about this ages ago, where we used to live was in a terraced house in a very dense part of Cardiff. And there were lots of cats, and Stuart is a bit of a feral. He was adopted from our garden, a feral animal that brings home pizza and goes hunting for ribs. But he was getting fights on a regular occasion, and he was also getting urinary calculi and other issues with his and looking like he was getting cystitis and bleeding. And I took him to the vets quite a few times in 1 year, and then the vet gave me lots of information and said, your animal has bladder pain syndrome. And I was like, how can this be? I know a lot about bladder pain syndrome in humans. And the vet gave me more information than any of the consultants that I had been working with at that point, and gave me this thing about dietary changes, helping the animal with exercise and stuff, but then also environmental enrichment. And they talked about playing with it, giving novel toys to improve its mood, hormones, that kind of stuff to help with the pain. And I was like, wow, this is amazing, as well as pain relief. As it turns out, we moved house to a slightly leafier area of Cardiff where there are far fewer cats. We haven't been to the vets in over 18 months now because he hasn't had a fight. He's got lots of things to play with. He's now got lots of kids' toys to play with. He's a happy cat, and he doesn't have any active symptoms.
Have a happy bladder?
He has a very happy bladder because all we did is environmental enrichment, a little change in his diet. Played with him more and stroked him more. So environmental enrichment works. It doesn't necessarily mean that we should all move to Puerto Rico, if we may not want to, but definitely thinking about the holiday effect. When patients go on holiday, they feel better. They think it's because the heat helps my joints. Nah, it's because you're nowhere near where your stress is, and your stress is where you live. So next, we had a little thing from a group in Norway, and I think Carrie Bow was the second author on this one. I can't remember the author's name. But they did an exercise trial, very relevant to physiotherapists. And they did quite a strong intervention for 4 months, where there was exercise groups, there were home exercises, there were stretches, and there were like a range of intensity, with lots of requirement from people to kind of mark down and say how much they're doing. On average, I think they were doing about 50% of it, and they were very happy with the compliance of people doing it. And what they found was that there were minimal changes in pain and outcomes, but actually what they were looking at is the compliance of people doing a much higher level exercise. A very small group, a few people that took on intense level exercise of running. But what they tried to do is achieve the American the American Medical Association guidelines of doing 150 to 300 minutes of exercise a week, which is a lot. It's a lot when we try to get to our patients to do it. But it was about breaking those boundaries and saying to patients in pain, it's okay to exercise. It doesn't necessarily make your pain worse. If it makes your pain worse, let's change what we're doing to make it something that you can achieve. And when I talked to the researcher afterwards, because we were kind of all going, it's really interesting what you're doing, it just feels unachievable. What was the realistic, there were 2 people training at high level, and there were 8 people, I think, that it was a smallish sample, less than 30 people. What were they actually doing? She said, a lot of them were doing walking, hiking, some were going to the gym, but it was more the fact that when they were asked to do something, they then started bringing up, there was a difference between those that did it in the summer months and those that did it in the winter months, but they were starting to bring things up like, I've just started doing walking outside with a few little bits of jogging as my slight increased intensity. But I can't do that anymore because it's snowing, so I've been thinking about joining a gym or joining a group, and where I can do it. And the fact that patients have been able to make that change because they've been inducted into exercise being fun and being an appropriate thing to do when you've got endometriosis pain as a way of managing and coping with your symptoms. So I think that was interesting more from a social aspect than specific exercise prescription. But yeah, the paper will be out soon, I think she said.
Nice.
Yeah. Okay. So I recently talked about some stuff that our Melanie Moran has been from Canada, in the lab over there, has been presenting on allergy, and not on allergy, on kind of pelvic floor, and that group presented at the same conference with Professor Nickel, I think it was, on bladder pain being an allergy-like response, potentially, and the use of what's it called? Urovaccine as a way of reducing that allergy-like response, and they found actually incredible changes in women for 2 years after using sublingual, so a little spray underneath the tongue, really reduced UTIs in people that had recurrent UTIs. So this is really good. So now there's a move towards working out if there's any underlying issues with endometriosis. Again, in bladder pain syndrome, we know the evidence shows that non-bladder syndromes, as they call them, which are underlying autonomic conditions that have a potential common genetic heritage or antecedents are found, and it's really common, and the evidence is there's quite a lot of evidence showing that now, and they're exploring that with endometriosis. Is there a common underlying allergy autonomic issue genetically? So Licia Dimitriou at Oxford's a part of the Oxford group in the TRIP studies. I think it was it a TRIP study or not? I can't remember.
I don't know. I'm afraid I'd have to check.
Yeah, there were many posters.
I can check.
many posters from the TRIP group.
If this isn't one, still check it out. We'll add it to the links, because the
TRIP
network are doing fantastic work.
Really awesome. But what they looked at is patients with endometriosis, and they found no significant difference for the number of allergies between patients that have got endometriosis associated pain, bladder pain syndrome, pelvic pain. There was also no difference between people that have got pain and no pelvic pain, and people that have got bladder pain versus no bladder pain. So in all of the groups, there was no difference. However, there was a significant relationship between asthma and allergies that required treatment and an endo-associated pain. And they found that asthma can be used as a stratifying factor. So it's potentially a link to suggest that there is something underlying from an immunological point of view. And it was also, they found it was useful that to stratify the fact that allergies are very common in chronic pelvic pain, and it isn't just a perception bias that everyone feels that they've... So there was another study presented that when they had, do you feel that you've got more allergies than everyone else, was the question, and they said yes or no, and they did it in the group with endometriosis associated pain, and they did it in a group with controls, and everyone said yes.
We all have more allergies than everyone else.
Yeah, so the control group as well as the endo group. But this is quite interesting. So like a small little nod towards the direction that things are going, potentially in endo, as well as kind of mimicking what's happening in the BPS world. Little bit of a highly depressing study, but I think it's really important. There was a group of obstetricians from Holland who looked at adenomyosis. They looked at the risk. They did it as a retrospective. They looked at women that had a histologically identified adenomyosis, which means that they've had a hysterectomy, and when they've had a hysterectomy, someone's tested the womb for... They've had a hysterectomy for something, and someone's tested the womb and found adenomyosis within the womb. And they looked at their fertility and their issues around fertility, having been positively identified as having adenomyosis, and they found a higher associated risk of various obstetric complications. So they think that adenomyosis sufferers should be classed as high risk pregnancies, and it was all things to do with the placenta and the womb. The placenta was at more than a 1 times risk increase of placental abruption, hemorrhage, premature rupture of membranes, having an emergency C-section because of generally failure to progress. But then also a 2 times the risk of having hyperemesis gravidarum. So I asked lots of gynecologists to explain to me why there would be a greater risk of hyperemesis with adenomyosis and kind of what we're seeing in risk to the womb, and they didn't know. So that's coming up, but there's also an increased risk of preeclampsia, like 1.6 or something like that. No risks to the fetus, so there wasn't any increased risk of... There was a slight increased risk of miscarriage, but there wasn't any increased risk of like preterm labour or NICU admission, and no issues with the actual babies. But there was a higher risk for mothers. So I think it's really important that we are aware of that. If we've got any patients that have got adenomyosis that are aware of it and then are falling pregnant and we're caring for during their pregnancy, we need to be aware.
So I missed this one. So in terms of your takeaways,
Yeah.
would it be that if there's a known diagnosis and you've got a woman in your care,
Yeah.
is it something you'd say that actually this is probably worth having a chat with your maternity care team, your
Yes.
obstetrician?
Yes, absolutely. So they should be consultant-led. I don't think this is part of the pathway at the moment, but the risk profile is increased. So they should be consultant-led in their care. They need to be... I think they found that they had earlier admissions and things like that for delivery, but also like failure to progress and issues around it, and a higher risk of bleeding and hemorrhage. So they really should be in consultant-led delivery.
That's helpful, thank you.
Okay. So Friday's big finish. We're on to the keynote.
Our keynote on Friday evening was Daniel Claw from University of Michigan, who was historically a rheumatologist by background, but now a significant pain researcher started off with fibromyalgia, but also other widespread pain syndromes. And he was talking to us about the evolving understanding of widespread pain syndromes. And something that was really interesting was that he acknowledged that there are some things that we're continuing to learn about. There have also been some gains that we should just acknowledge and implement into our everyday understanding and our everyday practice. So he used the example of fibromyalgia, saying that, at the beginning of his practice, there were lists of however many tender spots across your body that you would check as the diagnostic criteria for fibromyalgia.
Poke. Yeah.
Whereas now it's acknowledged that it's a widespread syndrome.
The whole body, not just points.
And that our learning from fibromyalgia, or what he even called sub-threshold fibromyalgia, which was using some of the screening questionnaires to highlight and recognise widespread pain in other conditions, may be a helpful prognostic or predictive indicator of surgical outcomes. So he was pointing about what we know from hip and knee replacements, but actually now is also reflected in hysterectomy. So a quote from him, a slide featuring maybe in some of the data here, is that we can actually say that we now understand that what he referred to as sub-threshold fibromyalgia, so high score on some of the questionnaires that we'll link below, is highly predictive of surgery and opioid non-responsiveness in patients undergoing arthroplasty, such as knee replacement, and hysterectomy. So their longer term pain journey, but also their short term pain journey with that post-operative pain and opioid requirements. So that was really interesting. He then mentioned some of the previous work that we've already alluded to, mentioned the MAP studies, looking at pain within the pelvis, across the pelvis, versus widespreadness, and how we need to acknowledge, and we can now acknowledge, that non-pharmacological therapies across the different widespread pain states have an increasing body of evidence to support their efficacy. And he had a really nice table that we might pull up from a review that he did in 2014, where he published a hierarchy of levels of evidence that existed for the different non-pharmacological therapies, and then he updated it with his kind of 2023 version. Not published, the 2014 review was published, but he provided a kind of reflection of actually where those same non-pharmacological therapies now sit in the hierarchy of evidence and how much has moved up to the strong evidence category. And his conclusions really echoed the work of Helena and the presentations of Helena.
It was a nice kind of holistic circle of the day.
Yeah, talking about integrated, not alternative, integrated non-pharmacological therapies being first-line treatments in widespread and overlapping pain syndromes.
Of which the pelvis is overrepresented.
His team at the University of Michigan, nice pain research hub, have created a website called painguide.com, which I'd suggest you have a little look at too.
And fibroguide.com. Yeah, so we'll link those below. There's lots of really useful stuff on there. He's recorded sessions and lessons for people with fibromyalgia and with chronic pain about pain. So it's a really useful resource for us to be using with our patients. Okay, on to the final day, Saturday. If you've got this far, well done.
We're still here.
It's
actually Saturday right now.
It is
this
still
should
Saturday.
Be the freshest content.
Feels like a week ago, but again, Saturday began at 8 a.m. With medical treatment of endometriosis with Dr. Attila Bocker, summarising all of the medical treatments. What I will do is just put up a picture here and you can see the ESHA guideline and how there is a hierarchy of treatment, and it starts with the oral contraceptive pill and possibly continuous use of the contraceptive pill. Now, at the end of this session, we had two questions. The first was from Katie Vincent, which you're going to talk about. About.
So she asked, based on the data that was presented, would the speaker in fact recommend back-to-back oral contraceptives to avoid menstruation, based on the fact that dysmenorrhea is of course repeatedly cited as one of the biggest complaints from women with endometriosis, but also knowing what we know from Frank 2 and others' works, that actually primary dysmenorrhea in teenage years may unfortunately be a predisposing factor to persistent chronic pelvic pain in later life. It was a great question, lots of thoughts and comments, but unfortunately the speaker pointed out that actually there wasn't a consensus to say which would be better, but that actually obviously the evidence that we've now got could inform the advice we give our women, our patients, so that they can then have an informed decision.
Yeah, they can make a choice. So it's worth knowing that there is the option to have continuous back-to-back no periods as a way of managing it. Directly after Katie Vincent, who is, if you don't know, she's the leader of the Oxford lab, the endometriosis, where the TRIP study is based and things like that. The TRIP team is based. Directly after her, Dr. Pamela Stratton stood up, who's a NIH preeminent doctor running kind of like massive national healthcare issue responses in the US. So big deal, really good for her to stand up and be. She said afterwards, I caught her in the toilet, I don't know if I told you this, and she said she likes being provocative and saying things that no one else will, and I think that's because she's got to a point in life where she has the foundation and the absolute right to be able to say whatever she wants, because she is across the evidence. But she stood up and asked about the use of hormonal suppression and should we not be using it more, because it's known that women and men experience pain differently, and there is the great potential for that to be generally estrogenic in basis. So like the role of estrogen in our pain experience, how we how it's embodied, how it's expressed, how we feel it, and that it's a kindness to not direct our attention towards lesions and stop thinking about managing the lesions, but start thinking about managing the woman, her quality of life and her pain. And so focusing more on a truly holistic sense of healthcare, thinking about the woman and accessing those hormonal suppression to help her potentially bring down that endometriosis associated pain. Great.
And then it was back-to-back useful sessions. So the next thing in that morning session was predictors of medical treatment failure in patients with endo-associated chronic pelvic pain. So this was the work of, I hope I say this nicely, Bahi Fayek and Mohammed Badawi, who their team are based in the University of British Columbia, and there's a great hub there. You might notice that with some of the links we share, there's a theme for some of these hubs. And what they looked at was women with endometriosis associated persistent pelvic pain who were on medication management for their symptoms. Interestingly, across both hormonal medication and analgesia, broadly 35 to 50% of those interventions were described as ineffective. So we'll put up a slide now so that you can see a little breakdown of those, from the kind of most commonly used medications to the least commonly used medications, and then the rates of reported effectiveness. So they found that those with high pain scores, low quality of life scores, evidence of central sensitization, and high pain catastrophizing scores unfortunately found hormonal treatment to be less effective. And they are now using that in their practice, using those patient prompts to phenotype and advise women about best treatment options and likely success rates. This has not been published yet, but the manuscript has been submitted, and I'll definitely be keeping an eye out for it myself.
Absolutely. It's a really nice model of, we had a chat with them afterwards, and they've got a really lovely standard of care, their programme, as they call it, which is a very integrated MTT. So they've got physiotherapy and psychology and dietetics and nursing care and gynecologists and everyone. And
we spoke to them because originally this data was collected up until, I believe, 2017. So at that stage they were using 4 markers for their impression of central sensitization. They were looking at pelvic floor myalgia, the presence of painful bladder syndrome, abdominal wall pain, and irritable bowel syndromes. Whereas now they're actually using the
CSI score
as part of their PROMS pack instead.
Central Sensitization Index, which is a score of, if you score more than 40, you are essentially sensitized. Now, one of the things that's really important to point out, and we've had this conversation a little bit, it didn't actually come across in the whole conference, which was really helpful. It makes me feel a bit happier, and I don't know if it was just kind of hidden or if it just didn't happen, but there is a little bit of a move as more people have kind of come on the central sensitization bandwagon for it to be a diagnosis. Central sensitization is a scale in all of us. I like to use this as an example. I was once very ill and I was meant to be going on holiday at the weekend, and it was a Wednesday and I had an afternoon off. And I decided, even though I was ill, I was going to keep my eyebrow waxing appointment because it's important. And I went to it, and it was the most painful thing I've ever been to. It was so painful, and it was because my body was centrally sensitized, because I was a little bit under the weather. I was coming down with a cold or something like that. But it was so incredibly painful. I was sensitized, I was peripherally sensitized. So central sensitization is a range in all of us at all different times, and it will change possibly day to day, but less likely in our chronic pain patients. So
it's a continuum, isn't it?
It is a continuum.
Rather than a binary yes/no situation.
Exactly. So when we diagnose issues, talk about, it's like shades of grey. Central sensitization is shades of grey. It's not a yes or no, and it isn't an answer for why they haven't got a central sensitization pathology. Probably. It's a continuum. I think I've made my point. Okay. Then we went into digital health.
Yeah. Do you need a pause? Are you okay?
Have a cup of tea?
We had a break, and then we went into digital health.
Yes. Digital health, and we're just going to sum it all together. There were about 6 presentations on different apps and tools that are really cool. We just want you to be aware of. So there's a tool called the Pippa Tool. They're all apps, which is a 5-point questionnaire of different elements of endometrial pain or symptoms. bowel problems, bladder problems, that kind of stuff. Really simple, but it's being trialled in GPs as a subset of the Endozone research network, as a way of, they're trying to find ways to diagnose people earlier. So that's really cool. And so far, what they presented was about its acceptability and its usefulness and that kind of stuff. All I've got written down for the Endozone website is it's awesome, and there's loads of information and loads of resources that have been co-created by patients. So they had a really, really robust, beautiful, I'll put the picture up now, of the process they went through and how they created the Endozone website, the whole project, from, starting off with focus groups of women with endometriosis all the way through to kind of developing apps and whatever. So the website is really useful. We'll link it down below. Have a look at it. It's very useful for your patients to go to. It's freely available for everyone.
One of the next apps was one called My Endo. It's not out and about just yet, but the idea of the app is to support a biopsychosocial model of self-management for women with endometriosis-associated chronic pelvic pain. Comment from the audience was that it could really help lots of women with persistent pelvic pain.
Yeah, not just the
endometriosis. Pain. So what it is, it will pop it up a little picture because it looks to cover patient education, some pain science education, mindfulness content, yoga content, and other bits and pieces that are considered self-care toolkit for women. So the reason why I thought it was quite nice is that they have done a study looking at the efficacy when this was delivered as a face-to-face group. Maybe a little bit like a pain management program that you might already be familiar with potentially. So when the same content was presented in a face-to-face program, there was unfortunately no change in pain scores. Just like we were saying earlier, great to hear these things to avoid the publication bias, but there was significant improvement across quality of life scores. So they've now packaged that into online content, into this app that's the My Endo app, that they're now obviously looking at the efficacy of the online virtual form. But the early pilot studies were encouraging, and this will then hopefully be integrated and available free, they suggest, within something called the Lucy app.
And the Lucy app is a free app as part of a female research group, which is an app where they carry lots and lots of longitudinal study data. So it's an app that they're using. They put lots of questionnaires in. They get women to fill it out for 2 minutes a day and do lots of questionnaires repeatedly over a long period of time. We're talking like 1 to 5 years, I think they said. So that they can track the life course of endometriosis symptoms and look at how things are correlating and look at what the effects are of taking hormonal supplementation or if they have surgeries and things like that. There's lots of really, really useful, rich data coming out of it. But the Lucy app is being, I think they said it's something like 16,000 users already. It was a really big sample. So they're putting My Endo is
into
the Lucy app
coming soon
to be freely available. The female digital mindfulness, that's all that kind of stuff. And the other app was a fertility study. I just like the name of it because it's called ELFS. The Endo Longitudinal Fertility Study, which looked at how women are doing with endometriosis and studied lots of elements of their fertility. So what was really nice to see is, and I had a bit of a chat with the kind of lead researcher on the ELFS fertility app, or the person that presented it, if she isn't a lead researcher, who was lovely and was just so excited about the fact that with all of this technology and proof of concept because of the pandemic, how we've all had to go online to provide a lot of healthcare, there's just so much data that we can get in a much easier form that's less burdensome on the patients who we enroll in these studies, which is, a really vulnerable position for them to be in. We can be really less as least burdensome as possible by using apps to gather huge amounts of data, and even stuff like dietary, getting them to take a picture of their food every day and see how things are changing. So it's a very exciting period of time with lots and lots of digital creation.
A lot to learn from big data.
Yes. So the big keynote of the whole 3 days, and we were really excited because there were loads of people still there. There were a good 400 people still in the audience, and it wasn't just physios, was Laura Mosley doing a chat about 20 years on of pain science education, or pain neuroscience education, where we are. a little bit of chat about Coronation Quiche, a little bit of chat about catching people in the audience watching films on their phone.
It was a great example of great communication and great presenting beyond actually the content itself as well, wasn't it?
Yeah, he's very personable. He's funny. So, yeah, do you want to start?
Yeah, so he started off by obviously setting the scene for some in the audience who might not be so familiar with his work, some of the background they'd be familiar with, getting their attention nicely. And he said that something he was going to be focusing on throughout and not shying away from was the complexity of the topic of obviously persistent pain, introducing and discussing bioplasticity, and actually the boldness and the need for bold ambitions to keep driving things forwards and actually to deliver excellence and not just good.
Yeah.
Because later on when he was reporting about some of the meta-analysis, he was like, yeah, it's good, but we can go beyond that. So he shared some of the early work talking about obviously his previous endeavours that we're familiar with, but was talking then about how they've taken some of their target topics for what should be included in powerful pain education, pain neuroscience education. Target topics engaging the community with persistent pelvic pain, but then looking at what we should possibly consider the experts, the people who have actually recovered from persistent pelvic.
The recoveries.
People, not necessarily pelvic pain, but persistent pain. Sorry, I say pelvic without thinking. Persistent pain. And so with those groups, they looked at things that had helped their recovery, summarising those, and then looking at what they now call the essential pain facts. So I'll pop it up on your screen, but you can see that these are messages that maybe should be forming the foundations of our pain neuroscience education. That pain might protect us and promote healing. Persisting pain overprotects us and prevents recovery. That many factors influence pain. And finally, that there are many ways to reduce pain and retrain our pain system back towards normal.
So these are the facts that the people that have recovered, and it was a large sample, it was about
520.
Was it? Okay. People that had recovered, these are the key themes that when they were asked what helped them to recover, what do they think was part of their helping to understand their pain and recover.
But this was the point that he reminded us, that if we look at the meta-analyses that have happened thus far, we can say that passive pain neuroscience education is good, but not excellent.
The kind where we just talk at patients and we tell them things.
And so we're going to pop up now a really nice model of some of the work they're working at the moment, where they're moving from the passive to the active model of pain education and pain involvement to actively communicate these messages. And as he said, you've got to be a mover or be moved.
Yeah. Be involved, be inclusive learning. And learning only happens when the person that you're trying to get the concept across to are involved in their learning. So it's not about sitting down in clinic and telling someone about their pain or asking them if they want to know about pain anymore. It's about doing more active things with them or getting them to do stuff at home and come back in. But designing things a bit like a teacher would. If you think back to your best teachers at school, we know, and universities all over the country are moving away from lecture-based studies, and it's all kind of much more debate form or coming in and doing practical activities based on home learning. So you do the learning and the reading of textbooks and stuff at home, or lectures or watching videos passively, but then you come in and you work in the university on the active inference of the information, like putting it together, delving into it, which is what he's promoting us to do. And
then he pointed us towards some of the excellent work of Amelia
Marden, 2022. Millie's published quite a few things. One was a systematic review of the guidelines around chronic pain, endometriosis. Brilliant piece of work. We'll link Millie's publications below. But the four main findings from one of her research studies looking at the women with endometriosis and their experiences, the four main key themes that they wanted to get across were that a sensitised nervous system leads to overprotective pain, and saying that helps to validate me that my pain is real. Pain doesn't mean my pelvis is damaged, although sometimes it does. So that reassures me that my condition isn't getting worse. How I think, feel and see my pain can make it worse. So that enables me with many ways to manage my pain, and I can change my pain slowly, and that empowers me that my pain can improve. If we can get those 4 key concepts over to people, we can help them to make changes.
I think it was great to hear Lorimer explaining things simply, because I think there was a very broadly mixed interdisciplinary audience. But I think he moved nicely from some of the comments of the other speakers that he'd listened to, and then gently kind of brought the audience on a journey with him towards the idea of an embodied pain experience, rather than some of the previous models.
Didn't touch on predictive processing, but we'll let him get away with that because it was a well targeted talk.
Yeah. And I've got some little quotes that I was tweeting earlier, because I think, obviously, talking to you guys, you're probably already on the same page. But he was talking about the importance of validating experience. And he was asked by a consultant with a special interest in ultrasound diagnostics about what's the value of a clear diagnosis compared to potentially any kind of fear or concern. And what Lorimer said, which I thought was really beautifully put, was, let's encase any appropriate structural diagnosis in a respectful current understanding of complex pain. So that hopefully...
Speaks so well.
I know, that's why I had to write it down.
Encase it.
Let's encase it, reflecting the fact that diagnoses can be empowering and informative, but to avoid the fear that might be associated, let's package it so that, as he said, they don't then get concerned when they run off to Dr. Google, because we've already equipped them with the information and the understanding of how that might sit within a biopsychosocial model of their pain experience. He also said, quite rightly, because in a lot of the posters and the content, people have been referring to different measures of pain catastrophizing. But he quite rightly pulled up colleagues and others on the term catastrophizing, and said that despite the fact that the term is used in validated questionnaires, which can be powerful, we need to be cautious when we use that term, because catastrophizing may instead just be worry. And he said, let's validate the experience and that legitimate worry.
Yeah, so he said we should be calling it the pain worrying scale. Much better, which is beautiful.
Still could be a useful tool, but a nicer and a more appropriate term probably.
And there's lots of this, beautiful word pedantry. Which is not word pedantry, it's about moving forward in a way that's much more respectful of the patients and understanding that we have to have patients leading us in this way. So the move over the last few years towards the word persistent instead of chronic pelvic pain. Chronic has a kind of terminal social standard, it's can be thought of in lots of horrible ways when it really is just a term of time, in the Latin basis of chronos. But socially now it has different contexts, so using the term chronic is not particularly respectful. However, most of the guidelines still use the word chronic pelvic pain. I think when I reviewed it the other week, it was only about 7% used persistent pelvic pain. But I think we all are choosing to use the term persistent to be more respectful of our patients and to be more not a nocebo, not making things worse. So Lorimer was a great speaker. He always is. He's very, very, very good at putting across complex ideas. And I know that they've done a lot of learning about how to learn and how to teach and how to do these things. They've always been good at it. But there's certainly, if you've been to master sessions, if you've watched them this year, there's a real step change in how they're approaching teaching. So keep up to date with it. Master sessions is totally worth doing every year. They do it online. It's really easy to access. This year, the starting point of master sessions was Dr. Jane Chalmers, hero of mine, leading the way with pelvic pain research, and Millie's work, which was great. So I hope that you have enjoyed hearing a little bit of a catch up from the whole of World Congress on Endometriosis. I'd like to repeat that this is about a quarter of it, because although there were 3 or 4 sessions every day, 4 sessions every day, 2 keynotes every day, each of those sessions had 4 streams, and we tended to just go to one of them that was the most relevant. There were lots and lots more, there's 3/4 more stuff on infertility and immunology and genetics, lots of things on interleukins, and I went in, and if there were too many interleukins and I couldn't understand it, I went somewhere else. Lots of stuff on imaging,
So if you'd like more, maybe from the breadth of other professions that were there that may have gone picked a different stream, there was a hashtag.
Yeah.
Hashtag WCE 2023. Have a look. Lots of people were using that, and then you should get maybe a greater cross section from the other disciplinary speakers who may have been prioritised by other attendees.
Yeah, fab. And if you want to talk to us about anything, get hold of us on social media. We shall be back. We shall see you again at some point soon.